Hello, my name is John Stark. I'm here to discuss posterior approaches, the technique, pitfalls, and revision strategies. Here's my disclosure slide. I'm the inventor of the Diana and the Nadia methods. The Diana method is CE marked in Europe. The Nadia method is CE marked and now FDA cleared in the United States. I'm also a principal in Ilion Medical, the company which is developing these methods. To review, SI fusion has several options, including the straight lateral approach, the posterolateral approach, the straight posterior approach, the posterior medial approach, which is our area, and related posterior medial approaches. I'd like to make a comment about the recess and recess anatomy. We use the recess, we know the recess because we put the implant at the S2 level and then we fill this area with bone graft. This is real structure. It raises questions for me if this is depicted as a seam or a bone-on-bone circumstance where penetrating implants simply pass from one bone to the next. It creates biomechanical questions. Treatment of osteoarthritis should follow orthopedic principles. Here you see parasagittal films of the sacroiliac joint going from normal to a severely degenerative osteoarthritic joint. And I would point out there's no orthopedic procedure elsewhere in the body where painful degenerative surfaces are forced together and expected to heal. Nerves and vessels are intimately related to the sacroiliac joint. Here you can see the internal iliac artery becoming the superior gluteal artery and exiting between L5 and S1. If we strip these vessels back and look, you can see that this nerve is deformed across something which is beneath and prominent. This is, in fact, the prominent sacrum from a sublux SI joint, and this explains or would explain why a patient might have leg symptoms in the circumstance of sacroiliac disease. We believe that the arch should be reconstructed. Here you see the pelvic arch, which is analogous to a Roman arch, and we believe that placement of posterior medial implant in this circumstance supports the arch, which is biomechanically correct. This puts the implant, the posterior medial implant, under compression. If you look at this particular patient, here you see a total disc replacement, here you see a total hip replacements, and these implants are obviously under compression. The posterior medial implant is also under compression, analogous to correct loading of these structures. This should be defined. In order to reconstruct the sacroiliac joint, we point towards so-called Bonner's tubercle, which is the plane of the frontal and sagittal contours, and we place our guide pin directed at this point from the recess. Once this is created and as an axis, notice here that there is subluxation of the sacroiliac joint. We use that axis to perform a distraction reduction maneuver, and notice that the subluxation is corrected. And we believe that this is responsible for why patients will have improvement of their leg symptoms following this type of SI fusion method. In addition, of course, to the distraction method, there are cutting methods and cannulated tubes and C-arms in order to perform these steps, and we're happy to instruct anyone about how that works. The Diana and the Nadia are different. The Diana is machined titanium. The Nadia is machined titanium covered by titanium plasma stray and hydroxyapatite. Now this has real advantages. Plain titanium opposed by bone will develop a fibrous tissue layer. A Nadia, or an implant coated by titanium and hydroxyapatite, will get direct apposition of the bone to the implant. This has been measured by Musin et al., and there's something like 5 times as much bony osteointegration with hydroxyapatite coated surface. There are pitfalls to the posterior medial approach, and I'll mention 2. Make sure that you do enough surgery. In my hands, 10% of patients with an SI problem require something else at the same setting. This might be a decompression, a pedicle screw removal, or pseudoarthrosis salvage. In this circumstance, it's an AP fusion. Remember to support the physiology. These are 2 cases, both at the 3-month point. Notice the incorporation of this one and the failure of the incorporation of this one. This is vitamin D deficiency. Please remember to give your patients vitamin D. Revision strategies of the posterior medial approach. First of all, some issues to discuss. This is a solid fusion of the posterior medial approach. You can see a large bar of bone spanning between ilium and sacrum. Here's a non-issue. This is a patient with a similar picture, but when she went to an esteemed colleague in the community, he suggested that she needed, because of some ongoing regional complaints, that she needed an anterior approach to this remaining section of SI joint. And I will tell you that this is a non-issue. Please look somewhere else. This is solid fusion. Lucency indicates motion. You can see the lucency adjacent to the screw on the sagittal film of the implant and on this coronal film, or excuse me, axial film. The malposition is corrected when it's present. Here you see malposition to the iliac side, and this is corrected by a guide pin in the correct location and a new implant in the correct location. Sizes only change when it's necessary, and it's not always necessary. Navigation can also be used to place the implant with confidence. So the revision steps in a circumstance where you think you may have a loose Diana or loose Nadia. Confirm the location of the pain. Please notice that the pain is exactly over the SI joint. You must examine the patient closely to determine that it's not coming from somewhere else. Get good CT imaging and study it for lucency that's consistent with the patient's symptoms. This is after revision with the implant in the correct location. Now, to decide whether or not you will put an implant in the same location or in a new location, study the trajectory of the implant. In this implant, you can see that the trajectory skims the notch and hits the femoral head. Here you can see that the vertical shot skims the notch and hits the femoral head. In this circumstance, the implant is slightly superior and goes anterior. A slightly better approach would be to skim the notch and hit the femoral head, but this would be considered acceptable, and a direct replacement of the implant could be performed. So the way that's done is the guide pin is reintroduced, the old implant is backed out, and the new implant is placed either in the same location if the previous location was satisfactory, or in an improved location, usually moving it distally. Posteromedial approach preserves the sacroiliac joint. Notice that in each of these circumstances where some salvage was necessary by bone grafting this area, the SI joint is still present. And so in a circumstance, if there is a failure of healing, one has confidence that this is a stable circumstance and can be reapproached with simply bone grafting without new implantations if necessary. The posteromedial approach can be used to revise other methods. Here you can see loose metal with lucency adjacent to the screws, lucency next to the laterally based implant. Here we have a non-union line in a circumstance where the SI fusion was attempted with a pedicle screw construct. Here is a circumstance where the SI joint was damaged by a tunneling method analogous to a Smith-Peterson approach, and this was revised with benefit with a posteromedial approach. In a circumstance where the construct is painful, loading the SI joint abnormally, this can be addressed by removing that fraction of the construct which is causing pain and placing an implant with bone graft in this area. Here's a circumstance with bone graft replacement, that is, our bone substitute was placed in an attempt to fuse the sacroiliac joint. In this circumstance, this would never heal, of course, and so placed a sacroiliac posteromedial implant was placed. Other issues, bone stock issues. Here's a circumstance where bone graft harvest has compromised the iliac wing. This could never be revised by a laterally based approach, but a posteromedial approach can be revised since it reaches so deeply beyond the bone graft harvest defect, and the posteromedial protection of anatomy is ideal in this circumstance. Here's an interesting case. You can see a laterally based implant, in fact, which missed the ilium in a Diana, which was placed in an attempt to revise this, and also missed, and this was revised by removing this, bone grafting heavily this area, and then placement of a properly placed posteromedial implant with satisfactory results. Posteromedial salvage does not always work. Here's a circumstance very similar to the case I just showed with a large area bone graft defect and an engaged posteromedial implant. However, Removal of the previously placed lateral implants left these bone defects, and in spite of an early postoperative satisfactory appearance, this went on to fracture at approximately 6 weeks, even though the implant was secure and the SI joint itself went on to fuse. For some cases, there are no answer. There is the risk of some approaches resulting in terrible neurovascular injuries. In this circumstance, this laterally based screw was satisfactory. However, the next most proximal screw missed the drilling step, went anterior to the sacrum, damaging the lumbar plexus, and this woman woke up with loss of bladder control, loss of sexual function, and a right leg plexus injury. In conclusion, if one is to revise sacroiliac fusion, the options are limited. You have a posterior medial approach and you have lateral and posterior lateral approaches. I think we've shown that you need a plan. You need to have a revision plan for whatever procedure you do. It should be a plan B and there should be a plan C. Complications are less likely to occur if you follow orthopedic principles. The posterior medial approach, its revision and salvage are based on a return to principle, including the biomechanical loading of the implant, the preservation of bone stock, and protection of the neurovascular anatomy. Thank you very much.